Okay, welcome everybody to our webinar. I can see that people are starting to join us, so we'll just wait another few minutes for people to connect, and then we'll begin. So welcome to everybody that's joined us so far. We're just going to give a couple more minutes for other people to connect, and then we'll start. Okay, so I think people joining the webinar seems to have slowed down now, so I think let's begin. So welcome everybody to our webinar on the Transforming Prediction and Early Diagnosis in the Community Funding Opportunity at EPSRC. So I'm going to give a quick overview of the webinar plan for today. So we'll start with some webinar introductions. I will then give some background and context information to this funding opportunity. I'll then give everyone a summary of the opportunity itself. And then we're very delighted to be able to welcome 3 guest speakers today who will be sharing their perspectives on health inequalities and patient and public involvement and engagement. After that, we'll move on to your Q&A session, and we'll try to answer as many questions as possible in the webinar itself. So please do use the Q&A box in your Zoom. If there are any specific questions related to your proposal, then we may suggest following up outside the webinar. Also, just to let you know that we are recording the session today, so just please be aware of that, and the recording will be made available on the funding opportunity page on our website. So on the call today, we have myself, Kate Porter-Goff. I'm a Senior Portfolio Manager in the Healthcare Technologies team at EPSRC, and I'm the lead contact for this funding opportunity. We also have with us Philippa Hemmings, who's Head of Healthcare Technologies at EPSRC, and we have our 3 guest speakers. So we have Professor Vital Katikareddy from the University of Glasgow, who will be giving a talk today on key aspects of health inequalities and what to think about. We have Professor Mariam Shamanesh from University College London, who will be giving a talk on her perspectives on health inequalities through the lens of work that she's done through the EPSRC funded iSense project. And finally, we have Lynn Laidlaw, who is a patient and public contributor and patient researcher, who'll be giving a talk on patient and public involvement or engagement, or PPIE. On the call, we also have Kate Redding, a portfolio manager in the healthcare technologies team at EPSRC, and is another contact for this opportunity if you have any further questions, and John Badley from the healthcare technologies team as well. So I'm now going to give some brief background and context to this funding opportunity. So hopefully many of you are aware that we published our refreshed healthcare technology strategy in March of last year, following an extensive consultation and engagement process with our community. And we very much see the strategy as being co-created with our community. So the overall vision of the strategy is really to stimulate advances in transformative engineering and physical sciences research to have a significant impact in health and ultimately enable people to live healthier lives. We're now looking at putting our strategy into practice, and we see this funding opportunity as one way in which we are enabling us to do this. So the diagram on the left gives a summary of our new strategy, which has 3 key challenge areas that sit at the heart of the strategy. So those are improving population health and prevention, transforming prediction and early diagnosis, which is the focus of this funding opportunity, and discovering and accelerating the development of new interventions. We've also identified a number of important enablers that we feel research within health technologies should consider and address, and these are kind of shown in the outer segments of this image. So we see all these aspects and cross-cutting issues as being important to deliver our strategy, but I'd like to kind of highlight 2 that are particularly important for this funding opportunity that we want applicants to think about, and they are reducing health inequalities and patient and public involvement and engagement. So I'll now take us through a summary of the funding opportunity. So hopefully everyone's had a chance to look at our funding opportunity on our website. I'm going to cover the scope and remit of the opportunity and priority areas. We'll then spend a bit of time covering the health inequalities and PPIE aspects, and then we'll discuss the funding application process and assessment criteria. So the scope of this opportunity. So we're really looking for high quality multidisciplinary proposals for engineering and physical sciences research that focus on developing novel tools and technologies for accurate patient-specific prediction and early diagnosis of both mental and physical health conditions for use in the community. So by community, we are looking for tools and technologies that can be used in accessible community settings. So for example, this could be GP surgeries, pharmacies, community diagnostic hubs, mobile units, and home environments, as well as potentially other accessible community settings, which I've not included on this slide. So proposals must address one or more of the following priority areas. So these are new approaches for prediction and early diagnosis of disease for use in primary care and community settings. The second one is self-assessment tools to enable individuals to track their own health and inform diagnostic decisions. So for example, this could be monitoring technologies that will make it easier for patients to interact with healthcare professionals and provide updates on their medical conditions. And finally, tools for earlier and more reliable diagnosis of mental health conditions. So for the application to this funding opportunity, you'll need to specify which priority area you'll be addressing. So if your proposal addresses more than one of these areas, then we ask that you please kind of identify a primary priority area that you are looking to address. So I'll now give an overview of what we're looking for projects to deliver and kind of the key objectives of this funding opportunity. So we're looking for projects to deliver high quality engineering and physical sciences research up to proof of concept, addressing one or more of the priority areas I outlined on the previous slide. We're looking for projects to deliver tools and technologies that address a clear unmet health need and demonstrate how the research will provide added value and impact in the healthcare system. Projects should deliver tools and technologies for use in the community, as I described on the previous slide. And projects should deliver multidisciplinary projects, so utilising expertise across disciplines, and that could cover multiple research areas, for example, including novel sensors, medical imaging, artificial intelligence, amongst others. Projects should engage with relevant partners and diverse users of research, people with lived experience, patients, and health professionals, to ensure the research is really co-created and co-delivered from the outset. And projects should consider health equity in their research and look to embed equitable, diverse, and inclusive patient-to-public involvement and engagements in projects. And I'll talk a bit about this on the next slide. So moving on now to health inequalities and PPIE aspects of the opportunity. So as I mentioned, reducing health inequalities and PPIE are key enablers in our health technology strategy and are kind of central aspects to this funding opportunity. So for this opportunity, we use the term health inequalities to include varying definitions and interpretations of inequality and inequity, including kind of the unfair and avoidable differences in health across different population groups. All projects should consider health equity in their research and embed equitable, diverse, and inclusive patient-public involvement and engagement. We're really looking for clear evidence of genuine co-creation and co-delivery and embedded engagement with patients, people with lived experience, health professionals from the outset and throughout the research and innovation process. As part of that, we're looking for engagement with people from different and diverse backgrounds, so including those from deprived, underserved, or underrepresented populations. We're looking for diverse and creative routes to be taken to engage relevant partners. So within your application, we ask that you must submit a health inequalities and PPIE plan. So this is a 2-page document that must describe how you've considered health equity in your research, how you will engage with users of the research, health professionals, patients, or those with lived experience in the project, how co-creation and co-delivery and embedded engagement with partners will be undertaken, so what activities will you be doing, and how equitable, diverse, and inclusive PPIE will be embedded in the project. So we will provide feedback on your health inequalities and PPIE plan at the outline stage. So this will give you time, if successful at outline stage and invited through to the full proposal stage, to develop your health inequalities and PPIE plan based on the feedback that you get from panel, in order to submit a revised version at the full proposal stage where it will be assessed. We also encourage you to appropriately cost all your PPIE activities, thinking about compensation and payment for your PPIE participants along the way, and making sure that costs is fully justified and appropriate for what you're asking for. And this should be fully costed at the full proposal stage. So moving on to kind of funding and process. So each project can apply for up to 2 million from EPSRC. So there is currently a total fund available of £10 million, with the possibility of securing additional funding depending on the response that we get in terms of applications to this call. Each project can apply for up to 3 years of funding. The opportunity has an expression of interest stage that is currently open. So this stage will help EPSRC identify reviewers and plan for demand. So this stage isn't assessed, and the information that you provide in your expression of interest can change prior to the outline submission. But we ask that potential applicants please submit their expression of interest questionnaire by 4 p.m. on the 2nd of May. So the outline stage, which is currently open, closes on the 29th of May at 4 p.m. And the outlines will be shortlisted by panel for a panel at the end of July. Successful outlines will be invited into the full proposal stage, and you'll be given 10 weeks from notification to submit your full proposal, at which point it will go through postal peer review and then a prioritisation panel. So here's just kind of a visual overview of the timeline and stages for this funding opportunity. So we asked the applicants intending to apply to this opportunity, like I say, submit an expression of interest by the 2nd of May. The deadline for submitting outline applications is then 4 p.m. on the 29th of May. And the outline panel meeting is expected to take place week commencing the 22nd of July. The full proposal stage for those successful at outline stage is expected to then open on the 13th of August and will remain open for 10 weeks with an expected closing date of the 22nd of October. Proposals will be sent out for postal peer review and principal investigators will then be invited to respond to reviewer comments. And the prioritisation panel is then expected to take place in February of next year with a funding decision in March. It's March 2025. So standard EPSRC eligibility rules apply to this opportunity. So research grants are open to UK higher education institutions, research council institutes, UKRA approved independent research organisations, eligible public sector research establishments, and NHS bodies with research capacity. So here are the assessment criteria for the outline stage. So there's one main assessment criteria, which is fit to scope, which will be looking at whether applicants have demonstrated how their project will address a clear unmet health need and addressed one or more of the priority areas outlined earlier. Have applicants demonstrated how the anticipated technology or tool is beneficial and suitable for use in an accessible community setting? Have the applicants demonstrated members of the team are multidisciplinary and have appropriate expertise and skills to deliver the project? Have they demonstrated how the project will engage with relevant partners to ensure the research is co-created and co-delivered with users? And finally, have applicants demonstrated how the project has considered health equity in the research and how equitable, diverse and inclusive PPIE will be embedded in the project. So at EPSRC, we're looking to support a balance across the priority areas. So we don't have a quota for supporting like a certain number of proposals in certain priority areas, and we'll really be looking at the kind of applications that we receive. And finally, I just wanted to highlight that alongside this funding opportunity, standard proposals can still come in through standard EPSRC responsive mode routes at any time. So this specific opportunity is really targeted. It's a really kind of targeted, more strategic opportunity that reflects our themes in our strategy with a particular focus on diagnosis in the community, tackling health inequalities, and embedding PPIE. So we expect proposals to consider and address these aspects kind of over and above what's sought in standard responsive mode proposals. So that concludes kind of the funding opportunity summary. So we'll now move on to hear from our invited speakers. So first up, very pleased to welcome Professor Vital Katikareddy, who's going to be sharing his perspective on health inequalities. So over to you, Vital.
Great. So a pleasure to be able to speak to you today about this. I'm going to give you just a very brief introduction, so don't expect it to be totally comprehensive, but hopefully it will give you a few pointers for where you might want to look. Next slide, please. So what are health inequalities? So as was hinted at in the last presentation, they're typically defined as systematic, avoidable, and unfair differences in health outcomes that can be observed between populations, between social groups within the same population, or as a gradient across populations. So I'll unpack this a bit more in the next few slides, but they are seen across most health outcomes. So whether we think about things like mortality or more specific diseases, so for example, heart attacks, strokes, depression, etc., most health outcomes show evidence of health inequalities. Sometimes the distinction is made between health inequity to indicate unfairness versus health inequality, which can just be considered that it may or may not be unfair. Having said that, within the UK and in Europe, more generally, the terms are often used interchangeably. So we can think about health inequalities across countries. So, for example, from a global perspective, but today I'm going to focus more on health inequalities within the UK, which I suspect is probably of more relevance here. So next slide, please. So health inequalities, people often think about in relation to socioeconomic position, or sometimes referred to as socioeconomic status. So based on measures such as small area-based measures of deprivation, so the index of multiple deprivation, or other aspects of socioeconomic position, so things like how educated someone is, what their social class is, what their income is. So seeing health differences across groups with different levels of these variables. However, there are multiple other axes of health inequality. So we can also see inequalities by gender or by gender identity, inequalities by ethnicity, which were kind of particularly noted during the pandemic, inequalities across geography. So, for example, thinking of things like leveling up, and also inequalities by age or by disability. Those are just a few axes of health inequality. There are others, and you can see a more comprehensive list in that reference there. The other thing that is worth noting is sometimes it's worth thinking about different axes of inequality in combination. So, for example, the experiences and the health outcomes of low-income women might be quite different from low-income men, for example. So you can think of these axes of inequality intersecting. Next slide, please. Another thing that's worth noting is we can think of health inequalities as defined in relation to a gap between groups, or potentially a gradient where the greater disadvantage someone experiences, the poorer the outcomes. And the way you measure those things might be quite different as well. Now, for the latter, for the idea of a gradient where everyone below the most advantaged experiences adverse health as a consequence of health inequalities, that does not necessarily apply to all axes of inequality. So, for example, with ethnicity, it's not really a variable that's amenable to thinking of it in terms of a gradient, whereas things like socioeconomic position often are. And neither are better or worse than the other. They're just different ways of measuring the issue. Next slide, please. And actually, the issue of measurement can be quite tricky, and often within epidemiology and public health more generally, we try and compare outcomes across groups. And you can think of measuring inequalities in terms of absolute inequalities or relative inequalities. So absolute inequalities are typically measured by the difference in the outcome. So, for example, if we think about death rates since 1841, you can see that there's a difference of 2. So the risk difference there, the rate difference is 2. Whereas another way of assessing inequalities is relative inequalities, so looking at the ratio between the two. And actually, what happens for those two measures could differ. So it's possible that you might reduce health inequalities in terms of absolute inequalities, but increase them in terms of relative and vice versa. It is possible to reduce them on both scales or increase them on both scales as well. But the importance of scale can be quite crucial, and it's typically recommended to assess both. Next slide, please. So why do they occur? Well, there was a seminal report in the UK in 1980 called the Black Report, which came up with a number of explanations which remain a good starting point for thinking about health inequalities. So the first explanation, which was largely discounted and I think continues to be usually not the main explanation, but is the potential for there to be some kind of artifact due to data issues and the way that things are measured, especially over time. A second explanation was social selection. So this is the idea that rather than social disadvantage leading to poor health, it could be the other way around. And that seems to play a minor role in health inequalities. So it's not that it plays no role, but it's certainly a minority of the explanation. And then the next one, which is probably the evidence suggests is probably the most important, is around material explanation. So this is the idea that economic and structural factors themselves lead to poor health. So, for example, we know that things like living in poor housing itself increases the risk of experiencing asthma, or living in an area with high levels of air pollution, which often tend to be more disadvantaged areas, that in turn has direct health consequences. And then another explanation, which also has an important role, but probably less so than the material explanations, is behavioral. So this is the idea that, for example, certain patterns of behavior might be more common amongst certain social groups. So, for example, smoking or drinking alcohol to excess. It's important to note that some of those behavioral explanations are driven, at least in part, by the material circumstances as well. So these aren't necessarily mutually exclusive. Next slide, please. Okay, I'm not going to go through every one of these theories in detail, but just to say that there has been work to expand on that initial list. A few additional areas that might be worth highlighting are the idea of the inverse care law, which is that often medical care isn't delivered is more difficult to access in areas of greater need. So, for example, if you look at where GP practices are located, there are probably an underrepresentation of those within the most deprived areas compared to what's needed. Another important idea is the idea of differential progress as well. So often when a new intervention is introduced, it tends to be taken up more by the most advantaged, and that can lead to an increase in health inequalities. So it's important to think about how do we minimize that risk. Next slide, please. Okay, so this slide just kind of illustrates what would be seen as probably quite a common summary of what might cause health inequalities. So we're thinking about these inequalities, the health outcomes at the right here in terms of the effects, but they are probably driven by much more societal level factors. So things like the social and political environment, inequalities in income and power and so forth, and experiences of poverty and discrimination. So those fundamental causes then lead to the patterning of wider environmental influences. So, for example, inequalities in access to services or inequalities in the nature of the built environment that people live in. So, for example, I mentioned the issue of air pollution and its social patterning earlier. And then there are things that individuals experience within those wider environments, and they might experience inequalities in the type of work they're doing, for example, that then might have their own adverse health impacts. And so all of those then result in health inequalities. So you can see that services are potentially important, including, for example, things like healthcare, but they're also shaped by these broader social, environmental, and fundamental determinants. Next slide, please. So there are different approaches to try to address health inequalities. So we can think of this as a kind of a very simple typology of approaches. So one approach is that you just target the most disadvantaged people. A second approach is that you have a universal policy, but you have greater focus on the most disadvantaged. A third is that you have what might be thought of as a redistributive policy. So you're actually trying to mainly intervene in the more disadvantaged groups, and trying to kind of level them up, as it were, without necessarily improving the most advantaged. And then the last one is the idea of proportionate universalism. So you're trying to improve everyone's health, but you try and achieve benefits in the most disadvantaged to a greater extent. Next slide, please. So there are some principles for what's that have been written by Sir Michael Marmot about what approaches are most likely to reduce health inequalities. So there's a particular focus on the early years, so actually intervening in early childhood, especially between 0 and 5 and prenatally as well, can be particularly effective. There's the importance of trying to enable people to have control over their lives, employment and work being an important area to intervene on, as well as ensuring a healthy standard of living for all. So that includes issues related to addressing income and poverty and so forth. A focus on creating healthy and sustainable places and communities. And there is a role for strengthening the impact of ill health prevention. And then lastly, issues around tackling discrimination, racism, and ensuring environmental sustainability. Next slide, please. So in relation to prediction and early diagnosis, just a few points to note from the broader literature. So we know that interventions that require actions by individual patients and individual people often tend to increase health inequalities, whereas actions that target more structural determinants and things like how services are provided and so forth, to change those that require less individual action, tend to be more effective in reducing health inequalities. In terms of creating new prediction tools and so forth, we know that better prediction by itself is not necessarily beneficial and can be harmful. So there does need to be some consideration of if you're to reduce health inequalities and to improve population health, how do you ensure that actually prediction is followed by effective treatments and mechanisms of referral, follow-up, and so forth that reach all population groups in order to reduce health inequalities. Often when we're doing risk prediction, we often look at data sets, and it's important to note that there can be important biases that are inherent in data, and naive analyses can just reproduce those biases, which could potentially exacerbate health inequalities. So ensuring interventions do not exacerbate health inequalities in the area of risk prediction and early diagnosis is quite a challenge, but is definitely one worth pursuing. So hopefully that's given you a flavour of the literature on health inequalities.
Great, thanks very much, Vital. So I'm now going to hand over to our second invited speaker for this morning, Professor Mariam Shamanesh, who is going to be sharing her perspective on health inequalities through the lens of work done through the EPSRC funded iSense project. So over to you, Mariam.
Hi, everyone. So thank you, Vital, for a great introduction. I will be discussing, because it allows me to really talk about cases, I'll be just discussing which will illustrate ways in which, in our case, innovations in point-of-care diagnostics and information communication technology, when co-created with end users, really has the potential to decentralize care, and in that way, as Vital nicely described, structurally support the reduction of health inequalities and enhance equitable access to prevention and care. And my focus is on rural poor communities in South Africa. Next slide. So just in terms of understanding what the problem is, that by implementing combination HIV prevention to scale, UNAIDS had aimed to reduce HIV diagnosis to 500,000 per year. In actual fact, this has fallen far short, with 1.5 million new HIV diagnoses in 2022. There are over 8 million people on lifelong antiretroviral therapy in the South African public health systems. And so you can imagine that digitally enabled diagnostics, if linked to a pathway of care, has a potential to leapfrog the HIV care and prevention cascade into a new paradigm. And much like no mobile phones before it have done in many settings, widen access to care. Next slide. So just the study site, so you understand where we're working. It's a health and demographic site located in KwaZulu-Natal, South Africa. It's about 200 kilometers north from Durban. It's a rural and poor area with very high unemployment. And they're dirt roads and non-existent public transport. And this, I think, just practically illustrates how challenging it is for people to attend the 11 primary care clinics. And of course, this is particularly challenging for young people who both don't have the finances, but also may not be feeling unwell. In a representative sample of 15 to 30-year-olds that we recruited in a cross-sectional study prior to our recent intervention, we found that despite freely available testing and treatment in these public health clinics, 1 in 5 young women were living with HIV, half of whom weren't on effective antiretroviral therapy, and only 5 had ever taken prevention. And this is in a context where the older men and women have almost universal access to treatment. So here there's a significant health inequality by virtue of being a young person and living in this setting. Next slide. So the first intervention that I'm going to use as an example is really in the diagnostics. So Africa was MRC funded, but was embedded within iSense to truly co-create a new generation of mobile phone connected HIV diagnostics to support decentralized HIV care. What I really want to illustrate here, how critical the co-creation was from the beginning, engaging both healthcare users, but also healthcare providers to ensure that these innovations in diagnostics and digital pathways would be usable, acceptable, and feasible. Next slide. So the first step in terms of understanding inequality is understanding, if you're going to develop an intervention, who would be able to access it. And as you can see, just prior to our study, we wanted to understand what mobile phone use was. And 15 to 35-year-olds are more likely to be making use of their phones beyond calling and texting. The older people would not be able to access digital technology. They weren't using their phones beyond calling and texting. Smartphone ownership and access to data and digital literacy meant that even in this case, less than half of the young people would have had access to services. This has obviously improved over the past 5 years, but knowing this background when developing a digital intervention was critical, obviously, to not enhance or increase inequality. Next slide. But we also conducted quite extensive formative work with conducting in-depth and key informant interviews, both with nurses, the policymakers, and also young people themselves. And what emerged out of this were several features. One is just confirming what we had, what I described, the challenge of getting to clinics, that there was a significant cost for testing for HIV through primary healthcare clinics. There was a time and cost of visiting a clinic, stigma associated with HIV risk itself, even if they turned out to be negative, and therefore fear of judgment and discrimination by the community seeing them going into a clinic and healthcare providers sitting in the clinics. Participants, particularly men and young people, felt that mobile phone supported HIV testing therefore would allow them to explore their own candidacy for care in the privacy convenience of home or community, and therefore it's time saving, but also gave them autonomy as to when and how they would use it. But what they also suggested, because we know HIV self-testing existed at that time, that having it mobile phone enabled could overcome some of the psychosocial concerns they had about a young person testing alone, because they could access live support for testing. But there were some concerns around HIV testing would never be able to overcome the internalized stigma and the fear of HIV identity. So doing this formative work really made sure that we thought about this technology in the context of where it would be used. Next slide. The other thing, of course, is developing the technology itself. And Val Turb managed to develop machine learning algorithms for an application that would read and humble lateral flow tests, which is such an easy thing to deliver in a community setting. And a pilot field study of the algorithms deployed showed that the mobile application had a high level of sensitivity and specificity, and particularly when compared to human reading. Experienced nurses were very good, but newly trained community healthcare workers, which are a bit more like a lay user or a self-tester, didn't perform as well as the algorithm. So obviously the algorithm itself worked and could be used in the field. Next slide. But we didn't want to just look at how the HIV test was used. We wanted to understand how it would also link the person to a care pathway or a prevention pathway. And in the absence of an approved digitally enabled HIV test, we piloted a simulated pathway. This meant we took a consenting participant doing an HIV self-test in a room alone with the support of an app. But this photograph was read by a nurse in another room, simulating a application that's reading the test. Next slide. So overall, we did this with 70 young people, and nearly half of them were men. Next slide. All of them completed the test. One was positive and successfully linked to healthcare through that phone application. And 7 used the help button, allowing the nurse to talk them through the testing. Next slide. We did in-depth interviews after again, seeing how multidisciplinary social science component with the technology was important. And these in-depth interviews found that young people really liked the privacy of the testing and the security, but also having the security of being able to connect with someone if they needed help. But the simplicity of the application was crucial in this setting where smartphones weren't readily available, so people didn't have that much experience of using smartphones for things other than reading and writing, calling friends. Next slide. So in summary, our formative work showed that co-created mobile phone-enabled HIV testing is private and convenient and acceptable to users and providers, and supports this decentralization and community delivery of a cascade of care. Next slide. The second example I want to illustrate is the use of information communication technology, and really how co-creation has led to using a digital support that decentralizes HIV care in the community further, and therefore can really lead to primary prevention, screening, and earlier diagnosis of HIV, but other conditions such as common mental disorders, by bringing services closer to the population that need it in a cost-effective way. Next slide. So Tetanamine or Let's Talk, aims to improve adolescent and youth resilience to HIV. It's a digitally supported peer-led intervention where peers socially mobilize young people into mobile adolescent and youth-friendly services. And we are testing this in a stepwise trial to look at the outcome of HIV resilience. Next slide. So a little bit more about what these peer navigators are. They're aged 18 to 30. They're matriculated and selected by municipal and traditional leadership in their areas. And they spend some time mapping the health and social resources in their areas. They identify adult youth champions who can help them link youth to the resources they've mapped. They support solidarity and bonding amongst youth in their areas through youth groups and safe spaces. And they do these individual needs assessments where they tailor the package of support to the person's needs. And this is where the app really helps. A peer meets a young person and during a health promotion conversation will identify the young person's health or social need and also the urgency of the need. Is it high? Does it need immediate action? Medium, they can be referred to the clinic or a social worker. Low, there's no need and they can touch base in 3 months. This is entered into this mobile phone-based electronic clinical management tool, and an action plan is generated, that then is reviewed by the peer supervisors who are experienced peer navigators, and if needed, escalated to the Nurse and Social Worker Review Committee. Next slide. So this is a scheme describing how this bespoke electronic clinical management system, which is programmed onto mobile phones and used by the peers, the peer supervisors, the clinical and social work team, works. And what in essence this allows is that the electronic clinical management system allows a real-time action plans to be shared with supervisors, escalated the review committee and the mobile clinic staffs. It means we can do real-time integration of care and support between basically lay caregivers, the peers, and expert clinical and social services. It also provides program level data for evaluation. Next slide. So here you see the range of needs that the peers identify, and I'll use a story to illustrate why we think this peer-led case-based management really works in our setting to overcome some of the health inequalities and support young people. So if you think of Nondamiso, a 19-year-old girl whose father has died, whose mother was working in Johannesburg. After finishing high school, she leaves her rural household where she was abused by her uncle and travels to a small roadside town. There she has no social network and doesn't find work. She meets a 26-year-old taxi driver who is kind and gives her gifts and money. She feels obliged to have condomless sex with him because he's kind to her, but she doesn't identify as a sex worker, so she doesn't access services specifically for sex workers. Zonke is a trained peer navigator living in the area. She meets her and has, during a health promotion conversation, recognizes her low self-esteem, that she's lonely, that she's engaged in sex primarily for company and material support. And so she's able to create a health and social action plan that she can share with her supervisors. One, she asks the social worker to help Nondamiso get a voter ID so she can claim the social grants she's eligible for. Second, she invites her to a safe space to meet other young people so she develops some solidarity and support in the community. She provides her with sexual health and PrEP information and then sends an action plan electronically to the mobile clinic where Nondamiso will be seen and have an HIV test, receive sexual reproductive health support, and some HIV prevention, pre-exposure prophylaxis. Next slide. So in the first year, this model has reached nearly 12,000 young people, which is 76% of all young people in our setting with unmet health and social needs. The peer-led structured assessment really does mobilize the highest need young people. Almost half of those people that attend the services need HIV pre-exposure prophylaxis or start antiretroviral therapy, and about half need sexual reproductive health services, whether it's STI testing or contraception. There was a greater uptake of PrEP through this decentralized service than the facility-based primary healthcare clinics, even though both are free. And it attracts young men as well as young women. But not all high and medium needs reached even the mobile clinics. So even that is a step further. Next slide. So what I pitched to you is, can we combine these two findings and decentralize even further? Can we support self-care through having really good diagnostics that can be used in the community for HIV, for a sexually transmitted infection? Can we use this sort of ICT that I've just described, this digital enabled testing, with an electronic clinical management system to support a quick virtual consultation with a nurse or pharmacy prescriber, and so dispense STI treatment, antiretroviral therapy, or PrEP? Can peer navigators support this? Can they support the digitally enabled model of care, and therefore allow this electronic clinical management system to really provide virtual consultations and get treatment to people that won't even come to a mobile clinic? Next slide. So I hope I've shown you that digitally enabled HIV diagnostics and linkage to care is acceptable, feasible, and overcome some of the limitations of HIV self-testing alone. The electronic clinical management systems allow a real-time integration of decentralized near-person care provided by lay healthcare workers like a peer navigator, but allow them to be supervised and supported by clinical and social work experts. My hope is that I've excited you to think of how your innovations, co-developed with end users, will leapfrog this decentralization in health and social care, so much as a mobile phone did with telecommunication. This could increase equitable access and reduce health inequalities in screening, primary prevention, and care for HIV, but also other chronic diseases in low and middle income countries. Next slide. So I hope I've convinced you that innovations in near-person diagnostics and digital care, particularly if co-created with end users, has a potential to improve equitable access to prevention and care in chronic disease, reduce health inequalities, and support health and social justice. And it just leaves me to thank everyone at RE, the peers, young people, and wider collaborators within iSense, including Rachel McKendry and her colleagues. Thank you.
That's great. Thank you very much, Marianne. So now for our final speaker, I'd like to introduce Lynn Laidlaw, who will be sharing her perspective on patient public involvement and engagement. So over to you, Lynn. Lynn, I think you might be on mute.
I am, sorry. Yep, I just want to say thank you for the invitation to be here. Yeah, so I want to share some personal perspectives on patient public involvement and co-production in health research, and that's some of my contact information if anyone's got any questions afterwards. Next slide, please, Kate. So I've been asked, what have I been asked to speak about today? So how patient public involvement can add value to research. What does good PPIE look like? How can researchers ensure that the patient and public involvement and co-production that they do is equitable, diverse and inclusive? And what should researchers consider and think about when developing their health inequalities and patient public involvement plan, which is going to be a big part of the application for this opportunity. Next slide, please. So here's just some definitions. So the standard NIHR definition of patient public involvement that most people know is that public involvement in research is research carried out with or by members of the public rather than to, about, or for them. And I do a lot of work with the Co-Production Collective, who are based at University College London. And the Co-Production Collective definition and the values and principles that underlie the way that they work have been co-created by the community. So for us, co-production is an approach to working together in equal partnership for equal benefit. Next slide, please. So I really wanted to put up this slide because I think that positionality and perspective is really, really important. So you need to, this is my personal perspective, so it's important that you understand some of where I'm coming from. So I live with a rare disease and multiple long-term conditions. And this funding opportunity is really interesting to me because I had a 4-year diagnostic odyssey to be diagnosed with my rare disease. And what really struck me was that data is often collected about people. We don't input it. So I often wondered if I wrote about my diagnostic odyssey and the things that were important to me or the things that affected me, how would that compare to the data that is collected about me or what healthcare professionals wrote about me? And I think just understanding people's experiences of diagnosis, of prediction is really important. And I'm involved across the UK with multiple researchers, academic institutions and organisations. And I have worked as a patient researcher. I came up with a research idea and did some co-produced qualitative research where I worked as a researcher, although I don't have any research training. And I also am PPI lead for a couple of projects, including one funded by the EPSRC. So I see the issues firmly through the lens of my patient, participant and involvement experience. And I think it's really important to be open about that. And I've embraced reflexivity. And I would say it's not just for qualitative research. So reflexivity, examining and attempting to understand how your own beliefs, judgments and practices affect and influence the research process. And I would argue that that's crucial for patient public involvement and DDI. And I'd maybe ask you to reflect on what your beliefs, judgments and practices are and how they're going to affect what you're going to do and how you're going to work with communities. Next slide, please. So, I mean, I can't think about patient public involvement and co-production without thinking about power and about power imbalances. And early on in my PPI odyssey, it came to me that, you know, what if patient public involvement in co-production was a game? So do the people that you're involving have input into the rules of the game? Are we expected to play without sight of the rules, or are we given the rules in a different foreign language that we don't understand? Are we invited to play halfway through the game, or towards the end of the game? Are we only allowed to play certain parts of the game, or are we involved right from the start? Are public contributors the only people not getting paid for playing? And are we held, and you know, I hear a lot about this, are we held to standard or representatives that no other player is? Think about you and your profession. Would you be held to be representative of everyone in that? You know, can we be deemed too expert or too challenging to play the game? Too white, not black enough? You know, we all have these perceptions. And actually, who has the absolute right to play the game? You know, people can't get involved unless they're invited. So maybe these are just some things you might want to think about. Next slide, please. So how can patient public involvement in co-production add value to research? So this was the Value of Co-Production Research project, which the Co-Production Collective did, which was funded by some money from NHS England. And it was a mixed method study. And what we found was that the value of co-production lies in delivering outcomes that actually matter to people, efficiency in the long run, because you're reducing research waste, working towards social justice. And I think that the previous two presentations, we've got a better understanding why that's important. Empowering people and building capacity. And then that's got a wee asterisk in it, because this is people saying that they feel empowered, not the paternalistic notion of, oh, look at me, I'm empowering people. And connecting us as humans, working together towards shared goals. But we can't do that if we're not mindful of the power imbalances, and if we don't understand the values and principles that underlie working in this way. Next slide, please. So what does good PPI look like? So I would say that it's based on values and principles, not toolkits, frameworks, and methods. And there was a really interesting study by the Patient Experience Library recently that found that there's over 500 toolkits and frameworks have been produced, because we are arguably, we concentrate on an outcome rather, but you know, actually do these change the culture and the hierarchy in research in which co-production and PPI has to exist? Good PPI and co-production pushes back against academic hierarchies and cultures. Again, culture eats strategy for breakfast. I've already talked about the importance of being reflexive, but also honest. You know, be honest about what people can change in your proposals and what they can do, and then people can then decide if they want to get involved based on that. Good PPIE is built on relationships, conversations, and collaboration. You know, it's a relational way of working. And what you need to understand is that in order, you know, PPIE and co-production is very context specific, and it understands in the context in which it operates and the groups that you want to work with. You know, it will look very different, but the values and principles underlying it will be the same. Next slide, please. So, you know, so what does good PPIE look like? And I love this paper from Sarah Knowles and collaborators called More Than a Method. So this is the common thing we see. I hear this all the time. We put patients at the centre, we put patients at the heart. And actually, what does that mean? And, you know, who has agency if we're putting people somewhere? Next slide, please. So the group that did this paper, did this research, worked with an illustrator. And, you know, the current view of participation can often be this, oh, look, we've ticked the box for PPI. But how the group saw it was that patients and public contributors and people with lived experience were the axis. Next slide. You know, and we need to ask, who starts the cycle? Who gets to ask the questions? Who decides what is important about the proposals that you want to put forward? And are they actually coming from the needs that people have expressed, or what you want to do your research in? Next slide, please. And I think, you know, this is the banana-rama rule of patient-public involvement and co-production, because actually it ain't just what you do, it's the way that you do it and the values and principles that you come at it with. Next slide, please. So what does equitable and diverse and inclusive patient-public involvement and co-production looks like? So you work with people in communities. What we find is that sometimes researchers helicopter in, you know, extract lived experience and knowledge, and then just go away again, and don't feed back to people what their input changed. I think it understands that there's an epistemic injustice here, and that there are different types of knowledge and all have equal value. There is an emotional labour inherent in working with communities, especially underrepresented and marginalised communities, and an emotional labour for you as researchers as well. And I think it's really important to understand that. It doesn't treat public contributors as free goods, and Kate talked about the importance of costing your plans properly. It gives people control over the terms of their involvement, and which means that all the decisions aren't made in advance. And also it's mindful of intersectionality. You know, we're not just one thing. We are we have layers of privilege and experience and whatever, but not just the people that you're seeking to involve or the people that are affected by your research, but also how does your positionality and perspective, how does your intersectionality affect the way that you do research? Next slide, please. So now I'm going to go on to the doing. So what should you consider when developing your patient-public involvement plans? And there's a really nice paper by Christina Staley and collaborators called "Who Should I Involve in My Research and Why?" And that's a really important aspect of this. You know, and I think it's important to think really carefully about that. You know, who is your research going to impact? Who should you be working with? I do a lot of grant review, and often I see patient public involvement sections are quite descriptive. It's like, oh, we talked to this person or this group and they really loved our proposal and we had a cup of tea and ate some cake, and then that was that. Okay, so where's the evidence base? Have you provided evidence of what patient public involvement changed in your application? Who's going to write the patient and public involvement section? How did you embrace the productive tensions? You know, what changed as a result of what you're doing? Budget is really important. I often see applications that have, oh, we're going to do X, Y, and Z in the PPIE. I look at the budget, I look specifically, and there's no money in that. You know, so you need to cost your plans. You need to think about accessibility. What are the access needs of the people that you're going to be working with, and include plans for that. Training. What training are you going to offer people to enable them to work with you in this way? Who's going to take responsibility for managing, working together with people and communities? What experience do they have? Do you need to bring someone into your application to do that for you? And also, you know, increasingly funders are asking you to think about the impact of what you're doing and evaluate it, but just be aware that academic impact is much more centred around the outcome, whereas when you're working together with people, the journey is going to be as important as the destination, and how you feel about taking that journey together. Next slide, please. So just some final reflections from me. So, you know, and I've just touched on this, you know, the journey is as important as the destination, and you need to make space for reflections to embrace the productive tensions and build trusting relationships with the people that you're working with. And what I would say is that working in this way impacts on everyone's identity, and that being reflexive can be uncomfortable. co-producing, co-creating can be uncomfortable. And you might need to embrace that. You know, you've worked really hard as researchers to get to where you are, and it can be uncomfortable for people, you know, to come in. Your research is your baby, and sometimes we tell you your baby's ugly. I would say embrace productive tensions, embrace reflexivity. And what I say increasingly is be honest with yourself. Actually, can you work in this values and principles-led way? And if you can't, then understand that, because this is not a zero-sum game. You know, the emotional labour of being involved can be immense, and you can do great harm to people if you're not going to work with them in a values and principles-led way. And the last thing that I would say is you need to understand that research is hope. And when I was on my 4-year diagnostic odyssey, I knew that my diagnosis was out there and that diagnosis was the key to getting evidence-based treatment, and I never lost hope. And, you know, no one will care more about research than the people that it affects, the people living with the conditions that it affects. And if we didn't think that our unique experiences and perspectives could help, we wouldn't waste your time, because it's just too important. Thank you.
Great, thank you very much, Lynn, for your talk there. So we're now going to move on to the Q&A section of the webinar. So we'll do our best to answer your questions. I know that Kate's been answering some of them in the chat already. So please do use the Q&A box and we'll go through some of those now.
We have one just arrived, if you would like to tackle the first one, which is about, is collaboration with physicians or clinicians required?
So we're not specifically requiring collaboration with specific people like clinicians. However, PPIE is a key aspect of this opportunity. And so we'd encourage you to kind of consider collaboration with, you know, it could be healthcare professionals like physicians or clinicians, or patients or people with lived experience, but we're not specifically mandating, I guess, kind of certain people within those areas. So it's for you to kind of consider who are the most appropriate people that you should be engaging and partnering with in your application, and making the case to kind of peer review and the panel members.
And just to add to that, Kate, it may be that the time when you submit your application, you don't have those formal partnerships, but please do take the opportunity where you see the need for those to link, and your thoughts about how you might make them if your research were to be supported. We realise that sometimes, you know, partnerships we expect to be a sort of a dynamic concept.
Thanks, Bertha.
There is also a question about whether there are any guidelines on how to balance engineering ICT novelty with the applied aspects.
So we don't have any specific guidance on this. I guess kind of applications should be, you know, specifically looking at engineering and physical sciences research up to kind of proof of concept. But it's for you to kind of address the key objectives of this opportunity. And so, yeah, we don't kind of mandate a specific balance between the applied aspects and engineering ICT novelty.
If I can just add a little bit to that. There is information on our website about costs that you can apply for. So if you were to search, for example, for proof of concept, it shows that we fund research up to that point, roughly. So it means that just bear in mind what we as research councils can fund through our grants. The next one we have is primary care is often not about disease prediction, but about predicting high risk change for actions. Is that within scope?
So I think if you kind of have specific questions on what's within scope for your specific proposal, then we'd encourage you to kind of get in touch with us via email, and we can kind of look into that. I think, yeah, for this opportunity, we're really looking at, yeah, prediction and early diagnosis. And we'd encourage you to kind of look at our healthcare technology strategy, where we kind of talk in more detail kind of areas and what that involves.
But I was struck, and not to put Vita on the spot, about the flagging that, you know, risk in itself, identifying risk has consequences. So with all our research, and this call is no different, there is the focus for a particular sort of project idea, but, you know, the really, you know, the great proposals and the proposals that we like to submit always give some sense about the sort of the downstream potential impact. So I think thinking about the, you know, if you identify risks, what does that mean for the person? What does that mean for the onward sort of, you know, potential issues, the care pathway, the interface with other parts of the care system? We're not expecting these proposals to deal everything, but and contextualizing, I think, is really, really important.
There's another question in here which I think is really quite interesting, and this is about could applications be directed at, I'm not quite sure what NCD stands for, but NCD risk factors. So it's about risk behaviours as opposed to the disease itself.
Non-communicable diseases, Kate, just so you know.
Thank you.
Things like, often it's sort of like heart diseases or stroke or cancer, non-communicable diseases.
So the question is about whether there could be a focus on prevention rather than patient-specific prediction and diagnosis.
Well, I'll just say briefly, and then I'd be interested in what other people on the panel think. I mean, as UKRI, we put quite a lot of emphasis in prevention in a broad sense, and there's been a recently announced set of new funding for population health improvement clusters. So prevention is part of our strategy. There's obviously, you know, sort of there is a spectrum, but in this particular case, we decided we were particularly keen to look at it through the lens of prediction and early diagnosis. So that may or may not help clarify. So, but I'm always interested in ideas that challenge the remit, but we're not looking to stretch the remit, because I say there is quite a lot of funding and plans, including we've got some ideas, but we're the early stages of how else we might take a more prevention and population health improvement take on this on sort of health.
I mean, I guess one thing to say is, from my perspective, the prevention, so screening prevention into treatment from non-communicable, I mean, I talk about chronic diseases rather than non-communicable diseases because I think they all behave quite similarly. Means that if you're screening more, you know, if you're picking people up earlier through better screening, you will get more people onto primary or secondary prevention in some ways. So I guess in that context, it won't be sort of stopping people smoking, but you might be identifying people that would require a sort of more intensive intervention by screening them earlier and having kind of better ways of reaching people. So screening can be the test being better, but it can also be reaching people sooner because of the way you're doing the screening, or the screen being easier to do. So I wonder if that would fall in your remit.
Can I just say that I hate the word behaviours in this context, because I often feel it's very stigmatizing if only you change your behaviour, when actually I think, you know, what Vita you know said was that actually, you know, choice is a privilege, and that's what's really come out of Michael Marmot's work. You know, people make the choices that they can only choose what's available to them, and it's got to be seen in the wider context of the politics of austerity and what's been happening in this country. And any word of, I would run a mile if a researcher came to me to talk about a proposal around behaviours. Yeah, because it can be very stigmatizing.
I think we have quite a helpful question here. The question was, is the emphasis of this call on predicting outcomes at the individual patient level rather than at the broader population level? Because I believe the answer to that one is quite short. It's yes.
Yeah, so we're looking at predicted outcomes at an individual patient level as opposed to at a population level. We're looking for patient-specific prediction and early diagnosis tools and technologies.
With obviously some understanding about what that means for broader patient groups and the population at large. But if you like, it's the other end of the spectrum, rather than looking at the population and then drilling down, which is particularly my experience, which is limited, not as an expert, from a population where you're looking at sort of, interventions that you can deploy at scale. We are looking at very much from the other end of the lens, but understanding the onward, impact it would have from benefiting as many people in society as possible downstream.
I have a question about whether an investigator could be involved in more than one proposal to this call.
So yeah, we're not specifically limiting investigators to only apply to one proposal. I guess if that is the case, then you might want to kind of flag in your application how you would be splitting your time between the two, and you can ensure that you are able to contribute effectively and ensure kind of the delivery of the project. But no, we're not limiting people to only applying for one application.
We have a question about lab on chip or organ on chip are considered ways to study pathological conditions. Is such research in the focus of the call?
Well, we've not excluded it, so I guess we'd ask, where's the novelty? Where's the added value, and where's the relevant to, as we've defined it quite broadly, community settings, as well as within the context of looking at health inequalities and PPIE. So we absolutely haven't mentioned particular technologies.
Thank you.
Or excluded them, I should say.
Yeah. There's a question about would 10% of permanent academics seem little as involvement in a project? I mean, so what sort of proportion of academic time might we expect on one of these?
So again, I don't think we're specifically mandating like a certain amount of academic time. I guess you need to be able to demonstrate that you're going to be able to give enough time to the project to be able to kind of deliver that and make the case to kind of peer review and panels that you will be able to kind of be involved enough to deliver the project.
We have a question that echoes the questions from earlier about that prevention and the patient-specific issue. And it is that the term early diagnosis can mean different things. Is it fair to say that this call is really about screening?
Well, my reaction is no, but we're not excluding screening. We absolutely realise there is a continuum. Indeed, we've had some very interesting, possibly a little bit too technical discussions about when does sort of prevention go into early diagnosis, and of course there's feedback loops. So are we, is screening part of it? Potentially, yes. But I think, for us, the opportunity and the excitement of this call is drawing on the ideas, the knowledge and the expertise of our community. And we're really looking for people to respond to this framework and give their ideas of interpretations where they think engineering, physical science, influence and inspired research can really make a difference.
Thank you. And we just have one question remaining open at the moment, and that's, must clinical staff from the target community settings be involved?
So again, I think we're saying that we're not mandating that clinical staff from a target community must be involved, but we're looking, as we've said before, patient-public involvement and engagement and health inequalities are key aspects of this opportunity. So we want you to be kind of thinking about who are the most appropriate partners and people to be engaging with, whether that's clinical staff, whether that's patients, whether that's people with lived experience, and it's really who are the most appropriate people for your project, your planned project and proposal, and kind of making a case and justifying kind of your plans and explaining your rationale through your PPIE and health inequalities plan. Yeah.
I would just encourage everybody to have a look at the criteria, how the proposals will be assessed, and how you're going to make your case against those criteria within your proposal, so that you need to be demonstrating to the peer reviewers how you meet those criteria. Oh, and given that we are at 10 to 12, I'm wondering whether this might be our last question. Would a digital tool or AI method be in scope? This would be for patient-specific risk predictions.
Yeah,
Yeah, if there's enough novel engineering and physical sciences in it, yes. The reason I say that is because there are a lot of AI and digital tools out there already. So I think some careful positioning about, you know, what is the added value, where is the potential impact, what's different about this one, and trying to put it in the context of a lot of awful related activity and likely future developments.
yeah, absolutely. Like Philip says, I think it, yeah, very much is within scope, but then also, you know, you should be kind of considering that alongside kind of the other key aspects of this opportunity, which is the health inequalities and PPIE and community focus.
Grand. That was the last of our open questions. In which case, it's very tempting to thank everybody and suggest that we call the webinar to a close. Are there any final comments?
Yeah, no, thank you very much, Kate. And if there's no more questions, then I guess that just leaves us to thank very much our invited speakers for the webinar today. So particularly Vital, Marianne, and Lynn, and also thank you to Kate and Philippa for joining us. And also thank you to attendees as well for joining us today and asking some good questions. And yeah, if you do have any more questions kind of remaining, or other questions that come to mind after the webinar, then please do drop us an email. You can either email myself or Kate directly, or send us an email to our Healthcare Technologies theme mailbox, which is on the funding opportunity webpage. So yeah, if there's no more questions, then thank you very much. And I suggest we close the webinar now.